So good evening, friends. I am Dr. Ajit Kumar. I am from Bangalore, and we welcome you all for this step-in session. This is about temperature, the temperature monitoring, and the hypothermia and the hypothermia. And we all know temperature is one of the most important vital parameters, which is always monitored in the ICU. And the accurate measurement of temperature is very, very important. You know that fever by definition itself in ICU, fever in the ICU itself says that the temperature, when the temperature is more than 38.3 or 101 degree Fahrenheit, then only you call it as a fever in the ICU. That means the temperature has to be 38.3 or 101 degree Fahrenheit. And we know that, in neutropenic patients, there are accurate definitions are there. 38.3 or single episode, or, more than 38 for, more than 1 hour. Some definitions are very, 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 very clearly defined. So the accuracy of the temperature measurement is very, very important. That is one thing. And the hyperthermia, and when the temperature is abnormal, naturally that triggers a lot of, further evaluation, monitoring, and further investigation in the ICU. We all know. So today we have an eminent speaker, Dr. Rawal. He is going to talk about the measurement of temperature in the ICU, and there'll be a mentioning about the hyperthermia and hypothermia as well. Dr. Rawal is a senior consultant in intensive care from Ahmedabad. He has been a founder president of the Indian Society of Critical Care Medicine Ahmedabad branch. And he is actively involved in telemedicine ICUs also. So I invite Dr. Rawal to take over the session on temperature monitoring, hyperthermia and hypothermia for the students of IDCCN. Welcome, Dr. Rawal.
Yeah. Good evening, everyone. First of all, thank you, Ajit, for a kind introduction. We are thankful to ISCCM for hosting a very good session on temperature measurement. So quickly we move to the session. I think body temperature measurement is a very important part of a clinical practice as far as a critical care medicine is concerned. Temperature measurement in ICU is a day-to-day and very frequently doable procedures, and I think everybody must be very, very accurate and very, very precise regarding this temperature measurement. So let us go quickly about what is the body temperature and what are the factors which affect the body temperature. So basically it is a balance between the heat production and heat lost by the body. So in a body, there are so many metabolic processes are going on, so that produce a heat, and the body try to balance it by losing heat by perspiration, by means of respiration, or by means of radiation. By means of radiation, that means if you have a heat and if the things besides you is cold, then you radiate that heat to that colder structures. So that is an emission of the heat. Am I audible, Neil?
So yes, sir.
Okay. So basically the heat regulating centers that lies into the hypothalamus, that is between the two cerebri, two hemisphere. It is a structure, small structure that is called hypothalamus, that is regulated by hypothalamus. And as we discussed that the heat production in the body is by a cellular metabolism. Now we measure it by some different thermometers like a mercury in glass, electronic, chemical. We'll see in a future slide about the details about all this measurement. Next slide. So as we discussed, when metabolism increase, the more heat is produced. So when it produces excessively, like in case of fever, in case of trauma, in case of post-operative stress, in case of burns. All this in condition where there is an increased metabolism. So because of increased metabolism, there is increased heat. So then once it reaches beyond the normal values, then we can call it fever. So fever can produce by so many means, as I discussed, that because of this metabolic stress that we call as a catabolic stress, catabolism, because of some infection, like the pyrogens, either it is a viral, bacterial, fungal, so that pathogens can raise the body temperature. What is called a basal metabolic rate? So that is a rate which heat is produced when the body is at rest. So that is called a basal metabolic rate, and that is depends on the person's body surface area. Next. Basal metabolic rate is affected by so many hormones like epinephrine, norepinephrine, testosterone. So men have a higher BMR than women. Same thing, it is affected by the thyroid hormone. So if there is an increased thyroid hormone level in the body, we can call it a hyperthyroidism, where there is a increased metabolic rate, and because of that, the patient feel warm and the body temperature may rise. Same thing, because of there is a decreased thyroid hormone level in the body, we can call it a hypothyroidism. So because of that, the person's body temperature falls because of less metabolic rate. Now, voluntary muscle movements like exercise, that also increase the BMR and heat production. If the voluntary or involuntary muscle actions are in excess, then there is an excess shivering, and that can increase the heat production up to 5 times. So when there is a very high grade fever, you have a shivering. Next. So as we discussed that the hypothalamus act as a thermostat and they control the body temperature. Right? When the body heat rise above the normal, what the hypothalamus will do? It send a signal to the from the nervous system to cause a vasodilatation, sweating, and inhibition of heat production. So because of the vasodilatation, the heat can be radiate, can be conduced, or can be conveyed into the surrounding areas and can radiate to the outside from the skin through perspiration. Same thing, if there is a body temperature drops below normal range, the hypothalamus send a message for the vasoconstriction. So that conserve the heat. So that's how the hypothalamus balance the temperature. Next. Now, as we discuss that how the heat loss occurs, we know that the heat produced by means of metabolism, by means of catabolism, by means of some pyrogens, by so many things the heat is produced inside the body. But then heat loss is through radiation, like that is an emission of heat, through the conduction, like it just distributes the heat, like the convection, there is a circulation of heat, and evaporation, like there is an air movement if there is a moisture. So the blood flow from the internal organs carries heat to the skin, and then it radiates in the person's vicinity. The same thing, when there is a person's surroundings is more warmer than the person's body heat, then the heat is radiated to the body and it absorbs. Like in a very hot environment, if you go inside the hot environment, then the heat is radiated inside your body and then it get absorbed. When the warm skin touches a cool object, heat is lost to the object. So that's why we put a ice packs. It is like a radiating of the heat. So we put ice packs. This is just a basic understanding to understand why we are applying all these things. Right? Next. So air movements cause heat to be transferred from the skin to the air molecules by convection. We all know what is convection. like a cooking. When we cook, then the heat, the hot air goes up and the cooler goes down. So same thing in convection. The fast moving air from electric fan cools by convection. So we just increase the speed of the fan, right? When there is a fever. Another thing is that sweat gland also contribute for the evaporative loss by secreting sweat in response to the message from the hypothalamus. So you have a more sweating. So that is called a process of evaporation. So as water evaporates from the skin, it is transferred to the air, right? So in a calculation, approximately 800 to 1 liter of water can be evaporated daily from the skin and lungs. Next. Now, temperature is very important, as we discussed, that how it regulated, how the heat produced, how the heat is, how the body lost heat. So the measuring temperature is very, very important. As we know, the normal body temperature is 97.5 Fahrenheit to 99.5 Fahrenheit and varies considerably among individual normally. So temperature can be measured either in a calorie or in a Fahrenheit unit, right? We'll discuss just for our basic understanding only in Fahrenheit. So the temperature in a healthy young adults, that is 98.6 Fahrenheit, plus minus 2 or plus minus 0.2 or 0.3, right? So up to 99 we can consider as a normal temperature. In a day-to-day, it varies, right? So it varies into the from the average, from 98.2 to 98 point or up to 99. That depends on the heat produced and depends on the amount of heat lost. Some people may have a low normal or high normal temperature consistently. So we represent that is normal for them. That is normal for them. So this thing we need to understand. Next. So temperature readings we can obtain from various sites like oral, rectal, axilla, ear, and skin. So these are the main sites for the measurement. Now, broadly, there are two types of temperature we can call. One is shell temperature and one is core temperature. Now, shell temperature, that is a temperature which is to be measured on the surface, like axilla or on a skin. Now, that is relatively inaccurate measurement, because if you are in an air-conditioned room, so your surrounding temperature is very low. So if you measure on a skin or on an axilla, then obviously that give a low temperature, while your core temperature will be high, maybe high. So axilla and skin or the shell temperature is relatively inaccurate measurement. So the core temperature is accurate or near accurate temperature measurement, that is to be measured in oral, rectal, or ear, right? Rectal temperature are usually about 1 Fahrenheit higher than those orally, right? So this is a position that is called as left lateral position, Sims position. We'll discuss that in later on. And axillary temperature are relatively 1 Fahrenheit lower than that is measured orally. So by and large, if you look at all this site, the oral temperature is most commonly used method, right? If patient is not conscious, we can use a rectal probe. That is another most commonly used technique in the ICU. Next. Now, measuring tympanic temperature involve inserting the thermometer probe into the auditory canal. So tympanic temperature, ultimately, it claims that it is a good indicator of core body temperature. However, the most accurate temperature measurement, that is an intravascular thermistor technique. So you have to put a catheter inside the pulmonary artery, pulmonary vasculature, and that measurement is the most accurate, but that is not convenient. That is not convenient. So which is most convenient is oral, rectal, and tympanic membrane temperature. So these three are more convenient and more widely used. The most accurate is intravascular thermistor technique, where you have to put a catheter inside the pulmonary artery, and that is the most accurate, but that is not feasible. So tympanic temperature, how to measure that, we'll see in some few next slides. But that measures the heat radiated as infrared energy from the tympanic membrane. It is the same blood vessels that serve the hypothalamus. So the temperature is close to the core temperature at the hypothalamus, right? So that is most commonly used. The temperature taken with tympanic thermometer is not subject to variation caused by eating hot or cold foods, while the oral temperature can be affected by hot and cold foods, right? Smoking, this temperature is not affected by even smoking, chewing gums, right? But they're affected by the ear infection. There is a wax or a blocking of the canal, right? All these things can affect the temperature reading. Next. Oral temperature, as we discussed, is very convenient for older children and adults, right? It has also some limitations that we'll see in some few slides. So in order to obtain a more accurate measurement of oral temperature, you have to wait if patient has taken some hot or cold foods or liquids, or patient is smoking, or patient has just chewed some chewing gums. So you have to wait for ideally for 30 minutes before taking measurements. Again, rectal measurement are also accurate, but it has also some limitations that we'll see. Rectal measurement cannot be used for cardiac patients or patients who has a rectal surgery, or generally it is a choice for last resort. But we are using that in our day-to-day ICU practice because the patients who are on ventilator, we cannot use oral temperature. Next. Auxiliary temperature are taken when oral temperatures are contraindicated and tympanic or temporal artery thermometer is not available. As we discussed that it measures the shell temperature and they are less reliable measure. Next. So now we quickly go pros and cons about the different sites. Like we start with the oral, we have already discussed. We are just again revising these things because this is very important. So as we discussed that you cannot measure oral temperature when the patient has taken something hot or cold things, patient has smoked or patient has some chewing gums, patient has consumed chewing gums. So you have to wait ideally for 50 to 30 minutes. Right? The tip of the thermometer or probe with plastic sleeves that has to be should be placed in the sublingual pocket, so that just below the tongue you have to put that probe. Should keep the tongue down, close mouth, and keep the lips closed. So this is the technique. You have to keep your mouth closed and keep the lip tightly closed. Next. Oral temperature, as we discussed, it is a very comfortable, very easy. No positioning is needed. Accurate temperature when the proper technique is used. You must place thermometer tip into left or right pocket under the tongue. As we discussed, it is influenced by hot and cold fluids, but it is not influenced by breathing. Next. Previous one. Yeah. Again, it is still taking long measuring time, around 30 to 45 or 60 seconds. You cannot use in a confused or uncooperative patients. You cannot use in infants and small children. You cannot use a patient with an oral surgery or oral trauma, or patient with a history of seizures, or patient with the chills. Right? So these are the limitations of oral temperature. You have to keep in mind. Next. Now taking rectal temperature, we are putting a rectal probe. So you can directly watch the temperature in on the monitor. But then in a conscious patient, if you want to measure, then you have to provide the privacy and ask the patient to turn to the side facing away from you, with knee slightly flexed. Drape the patient to reveal only the anal areas. You have to don gloves and lubricate the tip of the rectal thermometer. You have to lift the upper part of the buttocks slightly so the anus can be clearly seen. Right? Insert the lubricated bulb into the rectum directly towards the umbilicus, about 0.5 to 1.5 inch. And you have to hold the thermometer for at least 3 to 5 minutes or until the correct temperature is indicated. So there is a beep. Usually with the digital sensor, you got a beep. So when there is a beep sound, you have to hold the thermometer till that time. Next. Previous. Okay. So it is thought to be as accurate as the oral temperature. It needs lubrications, longer measurement time. It may cause rectal trauma, and you cannot use in a newborns, patient with ongoing diarrhea, or patient with a rectal surgery or rectal bleeding. A patient may be embraced, you have to reassure the patients, and patient must be positioned in a proper position, otherwise it is very uncomfortable, right? And you must document it as a rectal temperature. Next. Again, axillary temperature, we all knows that you have to put the thermometer center at the patient's dry axilla. A wet axilla, again, that produces a false reading. Ask the patient to hold the arm tightly against the chest. Again, you have to leave the thermometer at least 2 to 3 minutes or until the thermometer indicates the reading is complete. Next. We're not going much in axillary. It is safe and it is inexpensive. It is more often it is inaccurate, as we discussed that it is a shell temperature. The longer time needed, patient must be still, right? And you have to have measure. You must document it as an axillary temperature, right, and not an oral temperature. So this is a common measure. So in ICU we have a protocol that the temperature should be measured orally, or if patient is on a ventilator, you can put a rectal probe. If some patient don't wish to measure orally, you can measure as axillary, but you have to document that this is a axillary temperature. So the person that is coming next on the duty can understand that this is an axillary temperature. So he can verify or he can see the trend. Next. Now, the tympanic temperature, as we discussed, that it is also a very accurate temperature and very easy site to measure the temperature. You have to use a disposable single-use probe. It is also not affected by the food, drinking, smoking, by breathing, by positioning. It can be used with the all age group and with the most patients. So that is also very popular method of using temperature in outpatient departments. Even it can be used in newborns, infants, in the kids, even with the confused or uncooperative patients. So it's a very good mode of measuring the temperature. Next. But it can be affected by obviously impacted earwax, ear infection, whether ear tug is used. It should not be used in a patient with a ear surgery. Next. Next. Use correct ear to measure temperature. So if you are holding the last one. Previous one. Yeah. So if you are holding the thermometer in right hand, then use the right ear. If you are holding the thermometer, because whatever you are facing, that should be facing toward the front part of the face. So if you are holding the thermometer in right hand, then you have to use the right ear. Same thing, vice versa. If you are using the left hand, then use the left ear. Next. So now these are the common site of measuring the temperature: axilla, oral, rectal, tympanic. We know the best technique is intravascular, right? You have to prove a port, the catheter in the intravascular, and that will give the most accurate core temperature. But these are it is not a commonly convenient to measure in all patients. So the most accurate out of all these is, as we discussed, the tympanic membrane, oral, rectal. Right? Now we just understand the type of thermometer which was commonly used. Just have a glimpse. So initially that was used as a mercury. We know that that is a gold standard. The mercury with a glass tip, with a glass structure. But now that takes very long time. The mercury get heated and then it shows a temperature. Temperature gets stuck at one point. It gradually raising and then it just stop raising further. So we have to wait till it stop at that point. So that will take very long time. That can cause oral or rectal trauma. You cannot use in a confused patient. You cannot use in a children. So there are a lot of limitations. It can break. It can cause trauma. You are exposing to the mercury. So nowadays, the glass or mercury thermometer is replaced by the digital sensor thermometer, and it is also very accurate. Next. Another thermometer type is chemical dots. That is also not commonly used, but I just put this slide because we need to understand that this is a technique also. So there is a one strip that you have to keep under the tongue, tip of the tongue, right? There is a litmus paper, so that dots is there. So by watching the dots, you can see that this was the temperature. So it is a disposable. It is a chemical. It measures by the chemical process. Again, it is a least popular. So it is a disposable, single use, right? Again, there are a lot of limitations. So it is not nowadays not in a common practice. Next. Yeah. So the digital, that is most commonly used thermometer now, because that is a digital sensor based technology, very easy and safe to use. And that can be used to measure oral, axillary, and rectal temperature. Next. Now we have these automated temperature machines, right? That the electronic and infrared thermometers, which is convenient, very convenient. May save time and labor, but we know that this is a most inaccurate measurement. So we have seen in the corona time that every complexes or every mall or every society, you can find this thermometer, right? But then it measures the skin temperature, it measures the shell temperature. So it is not an accurate measurement, right? It is not an accurate measurement. It is just primary for a screening purpose. You can use it for a screening purpose. Next. Okay. So now we quickly move to the hyperthermia. Previous one. Yeah. So hyperthermia is a condition when the patient's temperature is above the normal range. We can call it, if it is more than 99, then it's a fever. But then there is a range, as we discussed, that 98.6 up to plus minus. We can call up to 99. It's a normal temperature. But as per the definition of hyperthermia, if it is more than 100.2, then it is called a fever or a pyrexia, right? And it reaches more than 101, then it is considered as a significant, right? So that is called a fever. We are not going into the details about the causes of fever, because there are more than 1,000 causes of fever. But the common cause, as we discussed, that because of fungus, because of some infection, either it is bacteria, fungus, viral. It is because of increased catabolic stress, right? There is a trauma, burn, post-operative status, right? All this can lead to fever, right? Very high-grade fever you can find when there is a more than 105, particularly that cause damage to the body cells, they are found with the central nervous system when it affects the center of the temperature regulation, like hypothalamus, where you have a very erratic temperature, like very, very high grade temperature. So that signifies that there is a significant damage to the nervous system. Or when there is a high temperature, it can cause significant damage to the nervous system. So when there is a high grade fever, because of the chemical reaction in the body, chills may occur, as we discuss. Next. So we know that the hypothalamus try to balance the demands versus supply ratio. But when the normal regulatory mechanisms cannot keep up with the heat production, at that time the fever persists, or fever, you can call there is a high grade fever, right? So altering the body's internal environments and allowing it to become hotter before triggering natural cooling mechanism permits the body to become more hostile to bacteria, right? So we can call it as a body's response to some insult. So by increasing the temperature, body try to become more hostile to bacteria, and the immune system become more effective to destroy them. So fever, by this method, we can say that is a body's response to cope up with any insult. It is a body's response, right? So that we need to understand. By having a fever, you can able to know that there is something happening inside the body, which body cannot cope up normally. So you have to be alert that there is something going on which we need to identify, right? So by this method, fever is good because that stimulates the immune system, right? Next. Again, body try to evaporate by means of sweating. So diaphoresis, that is called a excessive sweat production. So again, when the metabolic rate rises, we have discussed, we are not going again, that there is a greater demand for the oxygen at the cellular level, so fever occurs. So when there is a fever occurs, there is an increased demand for the oxygen, so patient may have a tachypnea. So that is a common findings we have seen, that the persistent fever patient may have some breathing difficulties, or patient may have a tachypnea because body try to cope up with the increased oxygen demand, right? Again, hyperthermia, as we discussed, it is because of the excessive exposure to heat or more heat production. Then hypothermia, again, it is caused by the prolonged exposure to cold. Next. In older patients, like more than 75, they have a lower baseline body temperature. They have a low BMR, so they have a lower baseline temperature, usually around 1 to 2 Fahrenheit lower. So if in that patients the temperature, if elevation of 2 degree Fahrenheit occurs, so that temperature, base temperature from 97, it rises up to 99. So we have to consider that is also febrile. So what I mean to say is the relative temperature, basal temperature is very, very important to understand, right? It is not a dictum that if fever, if the temperature is more than 100 or 101, then it is fever. No. If the elevation is more than 2 degree Fahrenheit, then also it is considered as a fever. So you have to be, you have to keep this in mind. Next. So that we have discussed. Next, if fever is very, very high for extended period, then it can cause convulsion, it can cause a severe dehydration, it can cause delirium. So these are the side effects of a persistent fever. So you need to address fever as early as possible. So as a critical care nurse, you have to see, you have to evaluate which are the process that you need to take part, that we'll see in some few slides ahead. Next. Now some few slides about the hypothermia that refer to a lowering of the temperature of the entire body, not just a portion of it, right? When the thermal regulator centers in the hypothalamus greatly impaired, when the temperature of the body falls less than 95 degree Fahrenheit, right? So the activity of the cell is diminished, the sleepiness, and if it persists for a longer time, then patient may go into the coma, right? So older adults, infants, they lose considerable body heat through the scalp. So wearing a hat even indoors helps to prevent them heat loss in cold weather. But same thing, people exposed to extreme cold, that leads to frostbite of the nose, finger, toes, right? Sometimes we have seen a necrosis, means we have to amputate the tip of the fingers. So that is the side effect of a excessive cold. Next. Yeah. So again, heat loss that occurs because of the prolonged exposure to cold. Sometimes it is intentional, in some surgery we have to induce hypothermia. You have to induce hypothermia in a prolonged surgery, in some prolonged brain surgery, right? You have to induce hypothermia. You have to be very, very careful when you do it intentional, right? Then you have to, when you are reversing it, you have to do it very, very gradually, right? Otherwise, that the metabolic alteration can cause a severe trauma to the body's mechanism, right? The early signs is uncontrolled shivering, right? Patient may become delirium. There is a loss of memory. There is some judgment. If that persists for a longer time, then patient may have a cyanosis, right? Patient has some arrhythmias. Patient may become comatose, right? And then, as we discussed, the patient may develop frostbite when it is body exposure to a subnormal temperature for a very long time. Right, so these are the side effects of the hypothermia. Hypothermia is not that common in our ICU setup, but we find, as we discussed, that in some induced hypothermia in some surgery patient or patient with a severe sepsis, you have a hypothermia where you have to address the hypothermia. Next. Right. So how we need to address the hypothermia? Hyperthermia, we know that we have to treat the cause, we have to give the antibiotics, but the hypothermia, the nursing activities for treating patient with hypothermia focus on reducing heat loss and supplying additional warmth. Like you can provide additional clothing or blanket for warmth, give warm fluids, right? Adjust the temperature to at least 72 Fahrenheit or higher, eliminate drafts, increase the patient's muscular activity, ask the patient to mobilize, right? Submerge the frostbitten area in a warm bath with water temperature more than 107 degree Fahrenheit, right? So that's how you can address the hypothermia in ICU setting. Next. Next. Now we quickly move to the nursing process as far as the temperature is concerned. So we know that these are the 5 cardinal points: assessment, diagnosis, planning, implementation, and evaluation. That's how you have to think about the temperature measurement and temperature address. Next. Again, the data collection assessment. Choose the appropriate site for temperature measurement based on the patient's age and condition and the type of thermometer available. Now you know that these are the choices available. This is the best options available. So it depends on the patient's age and patient's clinical condition. You have to choose the appropriate site and appropriate type, right? Determine whether any factors might affect the temperature reading. You have to address that. Check the electronic thermometer battery before measuring the patient's temperature, because a low battery may make the measurement inaccurate. Next. Now, nursing diagnosis. So, example of nursing diagnosis for patients with alteration of normal temperature might be hyperthermia, hypothermia, or ineffective thermoregulation related to neurologic injury. So, you should understand that why the patient has high fever, why the patient has hypothermia, or why there is whether this is a ineffective thermoregulation because of some neurological injuries, right? So, abnormality found on assessment of the other vital signs also indicate the problems in the various body systems. So you need to diagnose that, and you have to you have to write that, and you have to address it. Next. Right, you have to plan. So expected outcome are written for each nursing diagnosis. So the patient's temperature will return to normal after 3 days of antibiotic therapy, like that, right? So normal body temperature will regain within 6 hours, or the temperature again appear after 6 hours. We have to give the antipyretics every 6 hourly or 8 hourly. So that you have to write down, right? Depends on the diagnosis, right? Temperature will be maintained below 102 with the use of hypothermia blanket. So all these things you have to diagnose, and you plan accordingly. Next. Intervention, like that implementation. So take temperature on admission to the healthcare facility, so that a baseline temperature recording is very, very essential for a comparison for the future measurement, right? Take all the vital signs along with that, right? When there is a temperature, so you have to measure temperature every 4 hourly or 6 hourly. When there is a fever, then every 2 hourly you have to measure the temperature, right? Or when the patient is not feeling right, you have to measure the temperature, right? So that is your intervention. Next. Right? What are the nursing intervention to reduce fever? So you encourage the large fluid if it is not contraindicated, lower the room temperature, increase the rate of circulating fan with the circulating air with the fan, right? Remove the items for clothing or bed covers, like or warm clothing you have to remove, right? Control or reduce the amount of body activity, right? You can carry out the orders for cooling measures and supportive treatment, right? Cooling blankets, high calorie diet, fluids, medication, all these things you can have on your chart. Next. Previous one. And after that, you have to evaluate. So you have to evaluate what are the determine whether expected outcome have been met or not, right? Have your intervention helped to solve or alleviate the problem? So the evaluation is very, very essential to improvise the overall care, right? So after all these things, you have to evaluate yourself, and depends on that, you can modify your protocols for a temperature management. Next. Yes, you can make a difference. See, being a nurse, you are carrying a lot of responsibility. Whether this is a very, very, very small topic like temperature measurement, but it is an integral part of your clinical practice in the ICU or in the ward, and you can make a difference, right? So you have to just present yourself, in a welcoming way, right? That will reduce the anxiety and fear of the patients. You reassure the patients and the family, and be absolute precise about measuring the vital signs. Next. Thank you very much. Thank you for listening me for a very, very long time. I know I've taken at least 5-10 minutes more. Thank you very much.
Hi. Hi, good evening. Raj, you can hear me?
Yeah, I can hear you.
Yeah, that's fine. So thank you, Dr. Raj, for an excellent presentation. And, it is definitely discussed, definitely there's an exhaustive discussion was there, touching upon the nursing aspect of, temperature, measurement and management. And, so what I'm understanding is that the normal temperature for the discussion's sake, simple way of discussion will be normal temperature can be considered around. There is no definite number for normal temperature, number one. But as we said, for the practical purpose, we take it around 37 degrees centigrade or 98.6 degree Fahrenheit.
Yeah.
And the people call fever when the temperature is more than 38 degrees centigrade. The normal settings, 38 degrees centigrade or 100.4 degree Fahrenheit. But in ICU, we know that the definition of fever is different. In the ICU, the definition of fever is when the temperature is more than 38.3 degrees centigrade, or more than 101 Fahrenheit. That's what I want to stress to the students.
Yeah.
Is more than 100.1 Fahrenheit or 38.3 degrees centigrade. We know the conversion. This is easily available to Google. C by 100 is equal to F minus 32 by 180. That is a formula which you convert.
Yeah.
So we call fever in the ICU only when there is more than 38.3 degrees centigrade or 101 degree Fahrenheit. That's what I want to tell you.
Yeah.
And these measurements are very important. For example, certain group of accuracy is very important. For example, as I mentioned in the introduction, certain kind of people who are having neutropenia, the definition of fever is different, because there, the single episode of more than 38.3 degrees centigrade, or, as a temperature more than, 38 degrees centigrade for more than 1 hour, that's also considered as a fever. And as I already mentioned you, because any evidence of fever in the ICU, when it is documented, that triggers a lot of, evaluation of the patient. We look at the site of, infection. Obviously, infection, we may have a sense of fresh cultures. All these, it triggers a lot of evaluation, investigation in the ICU. There is no need to tell you. And, as doctor, the measurements can be, as you said, it can be, I'm just trying to make a condensed version of, what Dr. Rawal has already mentioned. We have, none of that, there is no definite gold standard for the measurement of temperature. But however, probably the most accurate, measurement will be given by, by a intravascular, thermistor in the pulmonary artery catheter, which is not an easy thing. Nobody can, use the pulmonary artery catheter, right and left. But
Yes,
ideally, the most gold standard would have been intravascular thermistor in the pulmonary artery catheter, but it's very cumbersome. And because pulmonary artery catheter can be used for other infusion of other drugs and other fluids also, it can still vary the temperature. It can make a difference in the variation of the temperature as well. But as we said, practically speaking, there are two measurements: as central measurement as well as peripheral measurements. The central measurements are, as I said, the intravascular thermistors in pulmonary artery, for example, pulmonary artery catheters. Other thing will be the bladder temperature, the temperature by thermistor in the bladder, or maybe in the rectal temperature. That is the central way of measuring, which is supposed to be more accurate, more sensitive than the peripheral measurements. The peripheral measurements, as we said, we use the oral temperature or the accelerated temperature. We use that. And and as you said, sometimes you commit hypothermia as well as hyperthermia, and there is a variety of severe extreme variation of temperature is happening with hyperpyrexia, because temperature is going above 41 degrees centigrade, or if you convert that into Fahrenheit, maybe around 105.8 degree Fahrenheit. Usually, it may very commonly it could be because of some kind of environmental factors, because the temperature in the environment is very high or low. I mean, very high, or maybe because endocrine effect, some kind of thyroid issues and stuff like that. Cortisol. I mean, the steroid issues, corticosteroid issues and all. So that's the thing. And another thing is, endocrine, which I already mentioned, certain drugs can use to this kind of very high temperature, malignant hyperpyrexia. Many people might have heard about that. So basically, these are the things when the temperature is too high. So these are the things we consider. Temperature can be low as well. Even in sepsis, sometimes the definition of previously systemic inflammatory response syndrome, temperature is too low. One thing we think about, obviously, is sepsis also. Yes. And obviously some endocrine thing we know on the myxedema and all. So people have to be very well aware of these things. And the measurement measurement has to be executed in the proper way, which has been mentioned. Dr. Raj has mentioned, that the amount of the time taken to cautiously measure these temperatures. And that is the message from this discussion, I believe. And any questions are most welcome. You can directly ask Dr. Rawal. You can even put it in the group as well. We can discuss. We are most happy to take any questions in this regard.
We are happy with the questions. Thank you, Ajit. Thanks, Ajit.
Thank you. Thanks for the excellent presentation again, Dr. Rawal. Yeah.
Need any questions?
Nothing, sir. Is there anything put in the chat box?
No, I can't find any.
I can't find anything. I can see 3 chats here. Just 1 second. Yeah. Nothing about the questions actually. Nothing about questions.
Okay, sir.
Any questions are there, friends? Please let us. You can just directly ask us.
So
You
there
can
is
put it in
one
the chat box.
Yeah,
You
there
can
is a
directly ask,
question.
you can put it in the
There
chat
is a
box also.
question. What is the reason for low baseline temperature in older and frail patient? So because of the age, there is a reduced basal metabolic rate. So as we discussed that the basal metabolic rate is responsible for your normal body temperature. So in older age, there is a reduced basal metabolic rate. So they have a reduced basal temperature. That is the reason. So you have to be very careful in elder patients, because as we discussed that even the deflection of 1 or 2, that is suffice to give them a severe decompensation. So a patient with an age of more than 75, if the temperature is just 99 or 90 or 100, you have to be very, very careful, because the basal temperature will be low.
Yeah, and just as adding to the point, see, whatever we have been discussing about fever and all, the fever may not be always present in patients, and as you said, it just varies. Elderly, in young people, you sometimes the fever may not manifest. It is not like that. It is always infections can manifest. That as a manifestation of fever. Sometimes even in immunosuppressed patients and all, like patient is on high dose steroid immunosuppression, sometimes the fever may not be there. Patient may not be able to produce this kind of inflammatory response, fever, the production of fever as well. So that is one thing. Another thing is that sometimes the patients, on RRT machine, renal replacement therapy machine, dialysis machines, and even in ECMOs and all extracorporeal membrane oxygenation, sometimes the fever may not manifest, accurately as it used in other patients. But obviously, all other patients, obviously, we need to monitor whatever is positive. We have to take, fever is there, fever is there. If it is not there, doesn't mean that there is no infection. But, still, that is one thing. The temperature can vary. That's what I want to convey. Temperature, the production of fever may be suppressed in those patients. It may be masked in those patients. Patients on RRT machines, obviously, there is already some thermoregulation is happening in the outside in the machine. These things may be masked as well. That is just wanted everybody to be aware. But when the fever is there, and obviously, as long as we need to monitor the temperature as accurately and as sincerely as possible, because an accurate measurement, that triggers a lot of evaluation and investigation in any ICU patient.
So there are 2 more questions. One is, as you discussed, we can consider only 101.3 only as a fever in ICU. See, as we discussed that the temperature in ICU, you have to be very careful. But then at least as per definition, if it is going more than 101, you have to see for the causes why this patient has a fever. So you need to address. As we discussed that there is a normal range, like a patient has a normal patient up to 90 and even up to 100, you can consider it is a normal. So the body try to compensate for that heat production. So, but when it goes beyond that, then you need to identify that why the temperature is going more than 100 or more than 101. So again, the number is not important. You need to understand that when the fever is more than 101, you need to identify. So that's why we can consider that yes, this is a fever and you need to address it. Right? How more time you can give injection Paracet? Paracet, that is paracetamol. That is injectable paracetamol. The concentration is 1 gram. So you can give up to 3 gram per day, right? More cautiously, there is a limit. 3 gram you can give. So you can give 8 hourly.
Yes. So basically, yeah, as Dr. Rajesh mentioned, there is no magic number. There is no magic number in medicine. Nobody can say, temperature, this particular time, this is normal, abnormal. But, for the teaching purposes, you need to have a healthcare workers, we need to have a trend to, to trigger our evaluation further. So as I rightly said, but unless the temperature is more than 38, usually we call temperature in the ICU, that's got definite definition. That is, unless it is more than 38.3 degrees centigrade, or if you convert into Fahrenheit, unless it is more than 101 degrees Fahrenheit, we won't define as a fever. But as you said, that also varies in certain patients, who fail to produce an inflammatory response. For example, for fever, the neutropenic patient is different. I told you, it may be a single episode of more than 38.3 degrees centigrade, or if temperature more than 38 degrees for more than 1 hour, that's also considered as a fever in the neutropenia patient. So these kind of definitions are given. As you said, obviously, I'm again reiterating, there is no magic number in medicine, magic number for human body, but this is just to have a uniformity, in the approaching the patient. You know what I'm trying to say, because there cannot be subjectivity. People cannot be keep on, investigating the patient just because, the temperature is acceptable with the normal limit. This to avoid this kind of over-evaluation, over-investigation, and to produce a uniformity, we make some numbers. That is what is really meant. There is no magic number in medicine. I totally agree with that.
Yeah, then another question is, should we keep in a patient in hypothermia after CPR? Yeah, I think post CPR survival, you can induce hypothermia. Again, there are guidelines that you can keep up to 32 degrees centigrade, but then that required a very, very accurate and very precise monitoring, temperature monitoring. You should have all the gadgets, because whenever from hypothermia, when you have to induce a normothermia, then you have to go it very gradually, and it has to be a regulated precision monitoring technique or methods that you have to induce hypothermia and you have to come back. So better we are not commonly practicing that hypothermia after CPR. Ajit, can you put some focus on that? Hello?
Yeah, we look for, in post-cardiac arrest, we look for some kind of a targeted temperature management. Basically, we, in our practice, we keep them at approximately around 36 sort of degrees centigrade sort of thing.
Okay.
And yeah, obviously, and hypothermia has to be closely monitored, because extreme hypothermia can have some theoretical, side effects as well, because, you can have, the coagulopathy, some sort of lactate level, some kind of an arrhythmias are there. But, targeted temperature management is definitely, it is well accepted even by with the current guidelines. So yeah, we do keep the temperature low, for after the unconscious patients who are after cardiac arrest.
Yeah. Old age patients in ICU, fever 99.8, you can again see there is no guideline that you have to give. But then if old age patients not comfortable, patient has a tachycardia, patient may have a tachypnea, patient feel fatigue, patient look dull, you can give paracetamol. There is no harm.
Yes, the paracetamol also, one small thing I want to add is just for, the sake is that we have an IV paracetamol and, we have oral paracetamol. And what I mean to tell you is that the oral paracetamol is as effective, bioavailability is as effective as IV paracetamol. So unless there is a definite contraindication not to give oral paracetamol, you can always give, you can always give oral paracetamol as well. That I just want to highlight that.
Yeah.
Paracetamol we use, obviously pain and temperature management, we do that. But oral can be used as much as possible, because, unlike the popular belief, just because somebody is given injection IV, it is not going to have a superior effect on anything. So unless it is definitely oral is definitely contraindicated, there is no point in using just the IV paracetamol also. I know that many clinicians still do that, but
yeah, but in ICU, it is a common practice to use injectable paracetamol. But yes, injectable and oral has the same bioavailability.
For some time, these kind of things, they may use some IV. But after that, you start through the oral feeding, there is no point in giving IV. You can just make it oral paracetamol. Yeah.
Yes.